Okay, I don't have time to mess with this. All right, so I'm already running really late. I've got an appointment in like an hour in town, and I don't know how I'm going to make this. So we're just going to do this real quick, and I'm going to try not to get too animated, even though this is like the pet peeve of mine. One being just a hair higher than this one, but this one being pretty severe. So we're going to get into it, and this may even flow into another video because I really got to get out of here. So PT INR is what I was going to talk about today, PTT, those types of things. So those are clotting times, right? So we'll say, what is your clotting time? What does PTT stand for? What does PT stand for? What is an INR? Those types of things are really important for y'all to know, and it kind of leads into my biggest pet peeve, and I don't understand why this is such a thing and why people don't understand it, because it's really not rocket science. I promise it's not that difficult, and for me, I feel like it's super common sense. So your PT is your partial or pro time, right? So it's your pro time, which is a number. It is in seconds. It lets you know how long it takes for your blood to clot. So when we talk about PT, that's kind of referring more to Coumadin than anything else, a couple other anticoagulants, but for the most part, your PT-INR is about Coumadin, kind of how it relates in your body. So you have to know how Coumadin works, and we'll get more into detail when we talk about meds. But Coumadin basically tells your liver to stop producing specific factors, it's like 7, 9, and 11, that create vitamin K, which in turn alter your clotting time, because it's all about time. How many seconds does it take your blood to clot, right? So if between 15 and 19 is what we're looking for, you and I clot about that time. If someone's on Coumadin, we want it to be a little bit longer than that. So basically what happened is the brilliant minds got together and said, well, if someone's on Coumadin, do we want them to clot at 24, 29, 32, 36, 44, 58, what number are we looking for? So the brilliant minds got together and more or less created an international normalized ratio. So that's a ratio that is saying kind of like your PT versus my PT. So it is 1 times or 2 times the normal clotting factor or the normal ratio to someone who isn't on Coumadin. So that's what that international normalized ratio is. It is kind of yours versus someone who's not on Coumadin, or that patient on Coumadin versus someone who's not on Coumadin. So when we say, 3.0 or 1.5 or 2.0, those are ratios. So the point isn't like a decimal point, it's kind of this ratio versus that ratio. So kind of letting you know how out of whack your clotting is. So if somebody is on Coumadin, it'll give you an idea of where how many seconds longer than your average clotter is. So if it's if they're taking twice as long for them to clot as it is for me, that is the ratio they come up with. So instead of trying to deal with all of this range of wild numbers, anything after 19 and anything below 100, well, instead of having this wide range, they kind of narrowed it and created the international normalized ratio. But you have to realize that it's still all about seconds. It's not about molecular weight, density, or viscosity. It is about seconds. How many seconds does it take you to clot? So it has nothing to do with how dehydrated you are or how hydrated you are. Thus, the viscosity of your blood, whether it's thick or thin, has nothing to do with clotting factors. Someone who is dehydrated versus someone who is in fluid overload doesn't necessarily have a different clotting time. When you start messing with the factors that form the cascade of events that create a clot is when you start messing with clotting time. That's why I would like to find the original individual who started using the term blood thinner and choke them out. Like, slowly watch the life leave their face as my hands are wrapped around their neck, because it makes no sense. It has nothing to do with thick or thin, viscosity, molecular weight, density, nothing like that. It's about time. And someone in fluid overload versus someone dehydrated doesn't necessarily change the time it takes for them to clot. any more than the length or width of a cut would ooze more blood or less blood depending on how thick or thin their blood is. That's actually a real thing. You could lose more blood if the cut was little and you were super hydrated because all the fluid could get out without slowing down. So when we talk about things like claudication, intermittent claudication, then you're going to see patients on actual blood thinners like Trental. It literally changes the viscosity of their blood and their plasma at the plasma level to make their blood more capable of getting into those smaller capillaries to perfuse those distal areas. That, like Trental, my students get all happy when I say, the patient's on Trental, this is the time you can say the word blood thinner to me, because it literally changes the viscosity of the blood at the prostaglandin level, altering the sludge of their blood so they can get to those distal areas. So people with intermittent claudication or poor perfusion, those are the patients that may be on this to open up, not necessarily open up the vessels, but to allow that thicker blood to get to those distal areas. That's where it changes the viscosity, molecular weight, or density of the blood to improve perfusion. Will those people clot any more or any less? Nope. You haven't messed with any of their clotting factors, so no, they're not going to clot any more or any less because they're not on any anticoagulants. So when you start messing with people's vitamin K and Coumadin, then you're going to see a change in their clotting time. That's why your PTT, your partial thromboplastin time, is tested in time. That's usually related to heparin, right? Because heparin kind of neuters your thrombin. So before it can get to that thromboplastin, that fibrinogen sheet, that fibrin, so before it can get there, it kind of like wipes it out and it decreases the molecular ability to form a clot. So if someone's on heparin, like someone comes in with an MI with active symptoms and we're worried about a clot, which is currently in a vessel, we don't want it to get any bigger. These aren't clot busters, they're not lysis, they're not thrombolytics. It's a thrombin deactivator, or I always kind of consider it to explain it to students, it's like neutering your dog. It's still there, it just can't perform like it normally would. Now that heparin is not going to affect every molecule of thrombin in your entire body, so you're not going to bleed to death with a heparin drip unless you don't follow the heparin protocol and end up with an issue, right? So when we get that heparin protocol and we check their blood with a PTT every 6 hours, we're looking to see what that number says so we can determine whether we need to increase it, decrease it, hold it, or bolus. So the number, which is in seconds, will tell us whether they are clotting too quickly or not quickly enough, and we're risking bleeding out or another clot. So when you see somebody on a heparin drip, you already know they have an active clot or risk of. You already know they probably came in with chest pain and rule out acute coronary syndrome, right? So, when I went in and saw a heparin drip and I immediately started to talk to the student about that, they're like, oh, how do you know all this stuff? Because that's what heparin does. That's all heparin does. That's what it does. That's all there is to it. If you learn how these medications work, read the action of the medication, the mechanism of action, and you're like, okay, it makes thrombin inactive. Let's just say an easier explanation is it makes thrombin inactive. So if thrombin's inactive, then all those thrombin particles, it kind of goes over there and like neuters that thrombin, neuters that thrombin, neuters that thrombin. So you're not going to see a drop in thrombin. If you drew thrombin out, you wouldn't see like, oh, he's missing thrombin. The thrombin that's there is deactivated. It's unable to continue the cascade events that form a clot, getting to that fibrin sheet, that fibrin, and then the final fibrin sheet that actually creates a clot. Just like aspirin, again, not a blood thinner, not altering molecular weight, density, viscosity. There's no thick or thin, nothing like that at all. Aspirin works on platelets, kind of like changing the elastomer of the outside of the platelet, making them slick and slimy and slippery. So instead of the Velcro elastomer that normally had, where they kind of aggregate and start to stick together and they all kind of come together, and then factor one's like, oh, what are you guys doing over there? And then factor 2, 3, 4, 5, calcium, vitamin K, and all the important things that create this clot. Instead of all those starting with that platelet aggregation, aspirin comes in and makes the elastomer, the outside of that cell wall or the platelet wall, slippery and slick and slimy, so it can't aggregate. That's why it is a platelet aggregation inhibitor. It's not a blood thinner. Doesn't do anything to thin or thicken the blood. That's not a thing. Water. You want to know what a blood thinner is? That's water. Water will thin your blood. That's it. That's what you get. You get Trental and you get water, and there's probably a couple others out there that I haven't seen, so I can't tell you about them. But if you want to thin someone's blood because they're significantly dehydrated and they're missing, plasma and everything else, all the particles are still there. All the electrolytes still should be there. All of their corpuscles should be there. All the factors should still be functioning unless they have liver failure or something else going on. But if you want to thin their blood, you can give them some water. If you give them Coumadin, not going to change the viscosity of their blood. What it will do is tell the liver to stop producing vitamin K, which will greatly affect their ability to form a clot, but not going to make them any thicker or thinner. For the love of God, stop saying it. I know we say it because we think people are too stupid to understand the term anticoagulant, but you know what? I managed to get through it. Yeah, a good 26 years. Don't know that I ever said blood thinner. At least I hope I did. I'm assuming Dr. Lentz, if ever he heard me, he, grabbed me by the back of the neck, shook me a little bit and said, come here, let me talk to you, dummy, and explain something to you. And now that I know that, and now that you know that, I'm sorry. It's painful. I know. I just opened you up to something painful. And Dr. Lentz did it to me also. That little pet peeve was the PACU girls would say like, oh, does this bed need clean? And it drove him insane, and it never bothered me until he pointed it out. Now it drives me insane also. You mean to be? You mean it needs to be cleaned? As it couldn't have told you that it needs cleaned? It needs to be cleaned? Yeah, Shakespeare was onto something. To be or not to be? Yeah, it's to be. Use it. Because the bed can't tell you if it needs cleaned. It needs to be cleaned. So thank you for that, Dr. Lentz, because now it's an additional pet peeve of mine, because Lord knows I don't have enough, right? Okay, so that's your basic PT INR run. We'll get into it a little bit more when we talk about liver failure and cirrhosis, and we talk about medications. We'll go in deeper, but I am really running late and I gotta run. So that is just your quick little 10-minute what to and what not to say. And really, people aren't that stupid. If you explain it, I just explained systolic hypertension to a little old lady having cataract surgery yesterday because her blood pressure was 142/48, and she's like, oh, that's high for me. Really? 48 is high for you? Oh no, the 142 is high for me. Okay, no, it's not, lady. It's where you live. I promise, it's where you live. You're 100 years old. Your arteries are hard as rocks. That top number is always going to seem higher than it really is. If it was really high for you, where'd the pressure go? What made a left turn? Gave up halfway? How'd your diastolic be 48 when your systolic was 142? Yeah, your arteries are hard as rocks. Welcome to atherosclerosis. Yeah, hop on some magnesium, lady. Okay, that's all I got for you today. Sorry, love you. I gotta run. I've got to get out of here. And of course, that's not going to turn off, and I do not have time to play with this, you piece of crap. All right.